I feel privileged to be here out of all the people that participated in the work. And I had a chance to strengthen some collegial relationships I already had and formed a whole bunch of new ones that are very, very important, and also one of the outcomes, I think, of the workshop. As some of you may know, on the front page of yesterday's New York Times, reporter Abby Goodenough describes a morning's work at the Family Health Centers, which is an FQHC in Louisville, Kentucky. Physicians and nurse practitioners are caring for Marshall Edwards with uncontrolled diabetes, a bladder infection, and a thyroid condition. Ms. Edwards stopped taking her medication for diabetes months earlier. Her daughter and her nurse practitioner agree that a combination of not being able to afford specialty care she needs, resulting depression, combined with a painful struggle to recognize her own illness, are important factors interfering with her health. David Elson, who has his own business but cannot afford insurance premiums, has chronic heart failure and chronic kidney disease. Imminent expansion of Medicaid will help him in Kentucky, but skipping an appointment because he cannot afford the fee, he now needs to go to the emergency room and is hospitalized because of complications from uncontrolled heart failure. Although not described in the article, similar issues arise in acute care and in prevention among children. Thank you. Pregnant women, adolescents, adults, including our geriatric population. At the same time, Family Health Centers are pursuing the challenging task of transforming their practice into a patient-centered medical home. Through their partnership with the local health department and funding from the CDC Transformation Grant, a consultant serving as a practice coach provides assistance that complements educational resources from the Kentucky Primary Care Association. In addition, the health center is implementing EHR, eliminating long waiting times by providing same-day appointments. Okay. Expanding, how's that? Their facilities. Gearing up for Medicaid expansion and increasing competitive marketplace while struggling to retain staff, provide competitive salaries, and support morale. Are we witnessing an unbridgeable gulf between core metric development and daily realities in Louisville, Kentucky? Although the healthcare sector is extraordinarily successful at generating measures which in themselves might constitute an epidemic, we now have a national quality strategy built upon a simple yet profound three-part aim in addressing cost of care, improving wellness of the individuals and populations, and the quality of care, including patient and family experiences of healthcare. Through public partnerships and sheer will, healthcare organizations, including safety net organizations like health centers and public hospitals, are putting these concepts into practice at the local and regional levels. As a National Health Center program, clinical outcome metrics are now shared publicly. Over 80% of health centers have EHRs, and we share a national goal of implementing medical homes. An aligned set of metrics that are actionable, document gaps and accomplishments, I should say almost effortless in its collection and analysis, I'm dreaming, yes, and eliminate the burden of duplicative and unrewarding reporting systems is crucial to support and guide the transformation illustrated at Family Health Centers. Rigorous follow-up of the IOM work group deliberations are crucial for strengthening consensus and the will to support the three-part aim for our country. Core metrics are an essential element in a larger cultural change to implement and publicly share results from a core set of metrics. Align payment, provide resources for technical know-how to bring current successful models and interventions to scale, and develop needed new techniques to improve gaps in care, affordability, and population health. Finally, only through a core set of measures will we finally know if our system has met its aims. Now, a large number of the measures that we discussed at our meetings address insured populations. The most recent census data for 2011 tells us that although the percentage of people who have health insurance has decreased from 2010, an estimated 49 million people have no insurance. Young adults, people of Hispanic origin, African Americans, the unemployed, low-income families, as you know, are most likely to be uninsured. Experts estimate that with the implementation of the Affordable Care Act and the uneven expansion of Medicaid, approximately 30 million people will remain uninsured. Although safety net health programs such as FQHCs and public hospitals provide comprehensive care for uninsured individuals, their care is often not captured with many current measures. Healthcare measures need to reflect our diverse nation and be rigorous enough to identify disparities among us. It is a powerful and important message that equity therefore permeates all three measurement domains in the report that you have before you. The workshop also identified infrastructure as an essential element of core measurement. Sharing mission and population health aims, family health centers in Louisville augmented their infrastructure through its partnership with the local health department. Not only do we need the capacity to collect valid information on a timely basis, the commitment, resources, and technical expertise to improve the quality and effectiveness of our health system allows our nation to devote its resources to the full set of our priorities, not just health care. After all, public health interventions, socioeconomic issues like education and employment, the environment, individual behavior influence health outcomes even more than clinical care. As a matter of fact, this is already happening through core measures. You know, I learned this last week through the Institute of Medicine Roundtable on Population Health, that the community care organizations being set up in Oregon, for example, some of the shared savings are going to housing issues. So this is a real thing that can happen because they've implemented a core set of measures. Lastly, we are witnessing the evolution of a health care marketplace. Will it evolve further into a health marketplace, informed with a core measurement set? One day, will core health metrics join the unemployment and inflation rates as part of our national dialogue? Will national and local partnerships be strengthened through a common language of measurement and improvement? Will individuals, patients, and healthcare professionals see and feel the difference in communities like the West End of Louisville? And if not now, when?